It's my pleasure to introduce Dr. Yael DeVere, who's the Vice Chair for Child and Adolescent Psychiatry, who will introduce today's speaker. Yael.
Thank you, Tony. So it is my distinct pleasure to introduce Dr. Kathryn Cullen, who is Associate Professor of Psychiatry at the University of Minnesota, Masonic Institute of the Developing Brain. She's also the Child and Adolescent Psychiatry Division Director at UNM. She did her training, her MD, her residency, her Child Psychiatry Fellowship, and postdoc in neurobehavioral research at UNM. And Katie, I don't know where you have time to do all of those things, but your CV is pretty impressive. As a clinician, she directs a division, directs the intense outpatient program, co-directs the early stage mood disorder program. She received Mentor of the Year award from the Center of Translation Science Institute. She has several funded studies, ours and other foundation studies, all in the area of neurobiology of mood disorders in youth. She has 104 total publications, and 50 of them are as first author, and she serves on the editorial board for the Orange Journal for ACAP. She's going to talk to us about neurodevelopmental underpinning of depression, self-injury, and suicide risk in youth, ideas to guide treatment design. So without further ado, Dr. Collins, please take it away.
Thanks so much, Yael. I will share my screen. It worked before, so fingers crossed. Great. Can you guys see my slides? Great. Well, so happy to be here. Sorry that I couldn't be with you in person. The pandemic continues to be a challenge. And I'm just in terms of disclosures, I will just noting that just some of my funding sources, and also that I have a consulting role for the FDA. So just diving right into it. So I'm a child and adolescent psychiatrist, and both my clinical work and my research has focused quite a bit on depression, self-injury, and suicide risk in adolescents. So the adolescent period is notable for an important time in which psychopathology emerges, and 1 in 5 people experience a mental health problem before they reach adulthood. The peak onset, age of onset of any mental health disorder is 14. And again, these issues that I've been focusing on, depression, non-suicidal self-injury, and I'll use the acronym NSSI in this talk, and suicidal thoughts and behaviors, they frequently emerge in this period, and they are related phenomena. They're distinct, but they're also related in the sense that they co-occur a lot, and they're kind of tough to disentangle. And they each increase risk for death by suicide. So suicide is a top cause of death for young people between ages 10 and 34. Kind of go over the years, these data, sometimes it's number 2, sometimes it's number 3. This is data from 2020. We lose about 6,000 young people per year in the US due to suicide. Again, these different factors that are associated with risk for suicide that I've been talking about, depression, NSSI, suicidal ideation, suicide attempts, the prevalence rates range across studies quite a bit, but you can kind of see they're pretty frequent and pretty alarming if you think about these high numbers of young people experiencing these problems, which are, again, risk for suicide death. Just a quick word on sex and gender, because there are differences in prevalence rates. With these different problems, with occurring more frequently in females than males, with that gender difference emerging after puberty. And early pubertal timing is a risk factor for adverse mental health. Some research has suggested outcomes in girls, but not boys. We think about this as we're still trying to understand it and study this issue, but likely due to combination of both biological sex differences, so for example, hormones or sexual dimorphism in the brain, but also experiential differences. So we have different cultural expectations and privileges, societal support versus discrimination for girls versus boys. And then also youth who identify as a sexual gender minority or identify as belonging to a gender minority group. these young people are at even higher risk for depression, self-injury, and suicide. So that's an important area of research as well. So I'm going to be zeroing in a bit more on NSSI, non-suicidal self-injury, in this talk, because I'm going to be sharing some results from a longitudinal study about kids with this issue. So what is NSSI? This is the deliberate act of causing damage to one's own body tissue without suicidal intent. Again, it typically emerges during the adolescent period, and it's diagnostic in the sense it does occur quite a bit in young people with depression, but also in kids with other disorders. And it also occurs in young people with no psychiatric disorder. So it's kind of an independent issue in that way. And I mentioned that there's been research suggesting that this behavior increases the risk for future suicide attempts. So several longitudinal studies have shown that. And what we think might be happening is kind of a practicing effect. So one of the theories for suicide is Joyner's interpersonal theory of suicide, where he kind of has proposed these three sort of overlapping components that lead to increased risk for suicide. So you can kind of see this thwarted belongingness, perceived burdensomeness, and capability for suicide kind of intersect to increase risk for suicide. And perhaps that NSSI is like this increasing this capability for suicide through kind of these experiences of injuring oneself, one's own tissues repeatedly. So taking what's going on, why the adolescent period? So this is just taking a few minutes to just reflect on what's going on during this adolescent transition, which is a really critical transition between childhood and adulthood. So of course we have puberty and the body changes that occur, and hormonal and physical changes that occur that are massive changes and that a young person needs to deal with beginning prior to adolescence and then into the early adolescent phase especially. We have key changes in brain and cognitive development that will be kind of especially zeroing in on some of the brain changes. Abstract thinking coming online. We have this relative shift in importance of relationships from family to peers. And in that, we have to navigate complex social relationships. So sometimes that can be extremely difficult and challenging for young people, especially when there's a lot of drama in their relationships, or it's, the whole idea of like sexual relationships is a new thing. So navigating that is a major challenge in the adolescent period. We see characteristically an increase in risk-taking behaviors for young people. And it's really like, this is the time when young people try on different identities and they have their identity formation. It's a very critical time for that. So all of this is happening during the adolescent period. And then at the same time, having these increasing demands on young people. So not just academic challenges, but also sometimes needing to contribute more to the household and financial and things like that. So what's going on under the hood during this time in terms of brain changes? So this slide shows some of the neurocellular changes that occur between like childhood and mid-adolescence. You can kind of see these neural processes are relatively sparse at birth and then super, super rich and dense at 6. And then again, like kind of thinning out at age 14. So we kind of think that this overproduction and then selective pruning kind of helps with generating complexity and then sort of honing in on the connections that young people choose to identify with, choose to do repeatedly, et cetera. So this is kind of happening in the background. And in terms of like trajectories of brain development. This is sort of a seminal study over 20 years ago now by Geed and colleagues, kind of where we began to understand these curvilinear changes happening in terms of brain structure. So for example, gray matter having these inverted U-shaped curves, peaking kind of around the pre-pubertal or the pubertal age for boys and girls. And then, but white matter changes increasing. So these changes thought to improve synchrony and integration in young people. And then these are, again, like this selection and pruning process that's happening during the adolescent period. And this kind of pruning process, this pattern of decreasing volume has been shown in other studies as well. And now like we also now have information on like different like subcortical regions and their trajectories. And I will say some of these earlier brain development studies have been conducted with ends of like, 150 or something like this. And now we have, we're kind of at an exciting time because of the ABCD study, which is this multi-site NIH funded project that is currently ongoing and is involving 21 sites and over 11,000 kids. And these kids are coming in over 10 years. I think we're really going to have a better understanding of what these neurodevelopmental trajectories are and looking at it in a bunch of different ways. So I think we'll have a better understanding of brain development than we do currently. But these kids are, they're currently, like 13, 14 years old. So we have to wait and see how that emerges. My group does have we have a fund grant to look at, we're again, especially interested in depression, self-injury and trajectories, developmental trajectories related to those problems, their risk and their onset. So that's something we're looking into. I would say since I don't have a ton to report about that yet, but here's one paper that is currently under review. It's not yet about psychopathology as much. It's more about brain development and puberty. So this is a little bit hard to unpack, but basically we're finding that the impact of puberty on like pubertal stage on the trajectory of cortical thickness varies by sexes in these brain regions. And so here you're kind of seeing like all the list of brain regions and the extent to which it varies by sex. And here you're kind of seeing like the trajectory in certain brain regions, how it differs by sexes in these specific regions. So these effects we were kind of thinking would be related to psychopathology, but we're finding that at this early stage, at least, it's not, but we're thinking that over time it will be. And there's other kind of indices of brain structure and function that need to be examined in the ABCD study and will be. So our group and many others are looking into this. And I think I just think it's an exciting time for that reason. So speaking about developmental plasticity, so across the lifespan, just thinking about all of the like developmental phases. I mean, the brain changes in the context of experience. So we have these dynamic changes in adolescence that I've been talking about. It might confer some instability and make adolescents more vulnerable to insults, for example. But it also suggests it could be that the brain could be more malleable. So kind of thinking about it as an opportunity, a vulnerability, and also an opportunity. So this is a picture from Dr. Tiffany Ho and her colleagues, kind of just summarizing the different factors driving developmental plasticity. And so kind of some here, like with these arrows, it's like these key core sort of developmental processes that are happening from before birth into and across adolescence, and all of these different sort of things that are at play in terms of, the intrauterine milieu and how we interact with our caregivers and different environmental influences. So I think these are all super important in thinking about the precursors and factors contributing to psychopathology, that like the ones that we're interested in: depression, self-injury, and suicide risk. And some of the processes might be, for example, neurotoxic stress leading to an inflammatory response, or some research has shown that, for example, socioeconomic status contributes to, for example, brain volume. So there's a bunch of different processes at play. And before I close this part of the talk, this introductory part of the talk, I feel I can't go without mentioning the COVID-19 pandemic, which is continuing to cause stress and distress. But especially, at the beginning when there was a lockdown and kids were needed to stay home from school for almost a year. I mean, my kids stayed home for over a year. And I think all of you parents out there, all of you clinicians who work with teens and young adults, you all know how much this pandemic affected our young people, and it differently depending on the developmental stage. But our teens really got hit. So interrupting this social interaction at a time when peer interaction is really crucial for many aspects of development. And we've seen meta-analyses that showed higher rates of depression and anxiety in teens during the pandemic. It did seem like there was some evidence that adolescents were more impacted by the pandemic than adults with respect to mental health. Lots of loneliness, which is a factor for depression. And it seems like there's evidence that this vulnerability to anxiety and depression is still going on. So it's not like the pandemic is over and now we're better. There's a lot of catch up and recovery that still needs to happen with respect to COVID-19. So with that, I'm going to move into talking about this study that we recently completed. It was an R01 project. It was an RDoC project, longitudinal study of brain development in adolescents with and without non-suicidal self-injury. So RDoC is this kind of NIMH initiative where you need to look at multiple levels of analysis at different domains. And this is a public data set. So and NIMH required us to, it's not all available yet, but I'm going to share with you, we've just been like barely scratching the surface of this like really rich data set. And I'm hoping to inspire some people in the audience to want to study it because soon it will be more completely available. And there's a lot of questions that could be asked with this data set that I'll never be able to do. My group can't do on our own. So that was really the spirit of kind of this NIMH requirement of having us upload our data sets to the NDA. So here's kind of the NIMH sort of RDoC description where you have these kind of different domains, negative valence, social processes, et cetera, and then looking at them across multiple levels of analysis. So for our project, we had 3 domains. So here's the first domain, sustained threat. So this is the idea that we felt that this would be relevant to adolescents with NSSI because a lot of them have either real or perceived threats. This is the threat system we know is like mediated by the hypothalamic pituitary axis and like amygdala prefrontal circuitry, responding to threat and then regulating the response to threat. And we had some data from our past work showing that actually, whereas adolescents with depression sometimes have like an elevated response to threat in terms of their cortisol responses, young people with NSSI have a flat response. So that kind of prompted us to want to study this again, like in longitudinally in this data set. The second domain was self-knowledge. Felt like this was really relevant to NSSI because young people, first of all, they're injuring themselves. It's an attack on the self in a way. And a lot of these young people have a hard time, struggle with their self-image and also having identity issues. So focusing on this, I won't present data on it, but this kind of system was evaluated, and we kind of focused in on this like medial cortical network that is known to be implicated in self-processing. And then the third system that we looked at was cognitive control because of the kind of the implication of impulse control in non-suicidal self-injury and suicidal behaviors. So to kind of share with you just a bit about this sample, we focused on female sex at birth. So wanted to focus on females with the idea that we just trying to limit heterogeneity. We know there's sexual dimorphism in the brain, and eventually, we wanted to increase power by not having to kind of look at having heterogeneity in there. And as you'll see, I can't just sort of say that it's females because not all of them identified as a female. So I'll share about that. We wanted to recruit like a range of non-suicidal self-injury severity. So what we did was we kind of created 4 groups. So there was the no NSSI group, and they could have, this was not a healthy control group. Like they could have no psychopathology, and they also were included if they did have psychopathology. And then, so as this was like a mixed group in terms of psychopathology, but they didn't have any history of NSSI. And then mild was like if you just had tried it a few times, or if you have done it a bunch of times, but it just has never been like tissue damage. So there's people that injure themselves a lot, but don't actually cause tissue damage. So that was considered mild also. And then the two moderate and severe groups both had, tissue damage 5 or more times, but they varied in terms of frequency. So moderate was less than once a month and severe was more than once a month. So we kind of like tried to get an equal number. Wasn't perfect, but get a range of severity across the sample. Here's our consort diagram. You can kind of see we didn't have the perfect attrition that we would have wanted. By time 3, we only had 77 people that had, we interviewed 90, 77 completed the MRI, 73 completed the Trier social stress test. So this was like what people completed in the study. What were some of the factors? I mean, when people got back to us, these are some of the reasons. Sometimes young people needed a higher level of care, like they were in a residential facility or something like this, or a hospital, and they couldn't come in. Sometimes they actually told us the study procedures are too stressful. They didn't want to come back in and talk about their self-injury again, or, so that was a lesson learned. I think these RDoc studies with multiple levels of analysis, it involves a lot of things, and it's kind of a high burden study. Some families were all in, they wanted to do it every time, and they came back, but it's not for everyone. So that's just something to think about. COVID-19, of course, really hit us hard as it did every researcher in the world. Sometimes the families just said, I have too much going on right now. And that kind of fits with, a lot of these people are, under significant stress, and doing one more thing is not always feasible. We did have one loss of a participant that was, it was not a suicide, but it was a tragic to lose a young person like this. So just to make a note of that. In terms of race and ethnicity, we did have some representation from different racial backgrounds, as noted here, but 79% of the sample had at least one of their identities was white. 16 people had, more than one race. And then about 10% of the sample identified as Latinx. And I mentioned to you that I was going to talk about gender identity. Unfortunately, at year 1, we had some issue. We had a problem. We realized that we had a problem with our data collection. There was some of our data, our gender identity data from the case ads was not usable. But so maybe focus on this last row, which is just if we had any gender identity at any time point. And so we did have 132 of our kids, we had at least at one time point collected gender identity from them. And this kind of summarizes if they identified with these categories at any time point. And so since there are some transitions, this if you add all of these together, it'll be more than 132. But just to show you, so about 83%, at least at one point, identified as female. And then some identifying as male, more so non-binary, I don't know, or other. And then I kind of summarized the transition. So there were 12 people that changed how they identified over the time points. And just kind of bring this up, we actually haven't looked at this data in detail other than to kind of summarize it for you, but I think this is, again, an important risk factor and should be looked at in the future. In terms of the baseline clinical characteristics of this sample, I guess what I'll maybe just highlight for you is if you kind of look at, so we have on the top, we have no NSSI, mild, moderate. So we're going more severe as we go more to the right. And you can kind of see that there's more past hospitalizations and more, suicide attempts in the more severe groups compared to the no NSSI group, which is kind of what you would expect. So these people have more frequent NSSI. They also have frequent other things. But we do have, psychopathology and interventions and suicide attempts, even in the no NSSI group. I just wanted to point that out. So actually the very first paper that came out was not neurobiology at all. It was just about emotion socialization. So this is how parents report their own responses to kind of how they respond to their child's emotion. And so we know that this is like a really important way that young people learn to regulate their own emotion, is kind of how they see how in the context of this relationship with their parent and their parents, how their parents respond to their emotions. And we found that basically the finding is that lower supportive responses is associated with higher severity. So when parents report a lesser degree of supportive responses to their child's negative emotion, that was a factor related to severity. Just wanted to underscore this because it is it's something that seems to be important, and in terms of thinking about how we can support these young people and the importance of the parent. So I'll get to that later. In terms of suicidal attempts, so at baseline, 33% of the sample had reported a suicide attempt, and these, then you can kind of see the lifetime attempts kind of being about the same at year 2 and year 3, which is interesting. But so it's a little bit confusing because some that we had attrition, but then there were new people that had suicide attempts that hadn't been reported before. I guess maybe what I will highlight is these two kind of numbers on the bottom right. So these are past years. So during the sample, we were able to capture 24 new suicide attempts that occurred during the time that these kids were in the study. So this is kind of important because this allows us to do things like predicting future suicide attempts or something based on the neurobiology data. In terms of reasons for suicide attempts, I think this is really important because it can help us think about how to intervene. Most of so we had we used the SITB, which is a standard sort of interview to understand suicidal and non-suicidal behaviors, and it asks these different questions. And the most common was impact of mental state at the time, and to get rid of bad feelings. And then these kind of other issues like social relationships were there, but less common. Rated. And then we also, they also provide just free form responses. And I kind of wanted to highlight this because it doesn't always completely map onto the ratings that I just showed you. So just to give you a little bit of kind of a richer picture of what's going on with these kids, I'm going to just read a few quotes. So for example, I get kind of aligning with that, biggest reason being just bad feelings. So big emotions I'm having, felt bad, outweighed the good, no happiness, couldn't handle it. And then unhappiness with self was a really big, really common thing. So feeling worthless, something triggered a bunch of self-hatred. I just felt disgusting, like I'm disgusting or something like this. So really bad thoughts about themselves. And that was kind of driving their suicide attempt. Sometimes kids actually talked about they felt something was wrong with their brain. And that was what they wrote down as the reason. Hopelessness and having no meaning, relationships. They talked about marginalization and discrimination experiences, feeling like a burden. So let me switch to NSSI. So similar in terms of the kind of these types of ratings. So impact of mental state and getting rid of bad feelings also being the top reasons, but feeling numb or empty being kind of a very close also. And this is like a higher one than it was for, the suicide attempts. And then also again, problems with relationships and getting out of things also being rated, but to a lesser extent. And so let me share a couple of quotes also from this, responses about reasons for self-injury. Again, feeling sad and stressed. So I have somebody just wrote self-loathing. I'm punishing myself. I felt like I deserved it. Again, like a brain sort of reason. I wanted to release endorphins. But there's more of this to feel better. I'm trying to make myself feel better. And again, bullying. And then they talked about, there was some that talked about a habit. It was a way to relieve stress, but it became a habit. So just to kind of summarize these different motivations, there's a lot of overlap. So they both, in terms of the motivations to self-injure versus a suicide attempt, they're both really like driven by these sort of like negative emotions and unhappiness with self. And then relationship problems, feelings of marginalization, wanting an escape, but in different ways, right? So there's different kinds of escape here. And both of them also noting issues with the brain. But with NSSI, you get this more sort of like motivation of, I'm trying to feel better. I'm trying to feel something. And then it's a habit. And then the suicide motivations are where you don't see this in NSSI is like meaning of life, hopelessness, and feeling like a burden. So just to give you a little bit of a picture of what these kids are going through and what they're thinking. I will now switch to neurobiology a bit. So focusing on the sustained threat. So again, with our multiple levels of analysis approach, we had this, these were our multiple levels. So amygdala, and looking at it a bunch of different ways, volume, activation in response to threat, connectivity with the prefrontal cortex. And then we did the Trier social stress test, which is like we have the kids give a cortisol sample, prepare a speech for 5 minutes, give a speech in front of strangers, and then they do math problems. So that's a 15-minute stressor, and we measure their cortisol response and also their reported response, and also how we observe their stress. So this is what I really wanted to this we published last year in developmental psychopathology, and we were able to replicate this issue where like the NSSI group. So this is the severe group. So we again see flattening in the NSSI group, but we mainly see it in the more severe group. We actually don't see it in the mild and the moderate group. So they had elevations in response to stress, and this severe group didn't. But all of the groups looked the same. Like in terms of how they reported their stress, they were similar, and they looked the same amount of stress. So that's basically the key takeaway from our Trier social stress test data at baseline. And we're currently looking at the longitudinal data. I don't have anything to tell you about the longitudinal data. In terms of amygdala activation, we had this finding where like the right amygdala was more active in moderate versus no NSSI. We kind of combined the no NSSI and the mild here because the mild was really small. And then connectivity, it was lower. You can kind of see the blue is the no NSSI combined with mild. This is moderate, and red is severe. So we had significantly lower connectivity with the between amygdala and prefrontal cortex at baseline with the severe group. So those are kind of some of the key sustained threat findings. And then just starting to look into, and I was telling Tony, I'm going to present some of this data like in a poster at ACNP next week, but just starting to look at the longitudinal data, and there's so much here, and we're just kind of beginning, but we have, so with our attrition, we've got, and after kind of excluding people that are, we can't use it because of motion or something like that. These are our numbers for longitudinal usable data sets for the resting state fMRI and the threat fMRI task. And then like, if you think about it in a different way, which is how many people do we have at least one good scan, or at least two good scans, or at least three good scans? These are smaller. So, even though I had we had 3 people at year 3, it's only not everybody like had done both year 1 and year 2, right? Because the thing is, sometimes they have braces one of the years or something like that. So these longitudinal studies are challenging, but we do have some good usable longitudinal data. Here's one finding that is new. So in terms of left amygdala activation to threat over time, we kind of had this difference in trajectories, and the one that was different was actually in this case for the mild group. So the mild is kind of like this blue color, and it's like increasing in terms of over time, whereas the none group was decreasing over time. And those are the 2 groups that showed, especially at this time 3 difference. And we also found that that overall amygdala activation and depression scores were positively correlated. So higher activation was correlated with higher depression. And even if you just look at this over time, like, change in individual differences, change in amygdala activation from year 1 to year 2, for example, correlated with increases in depression from year 1 to year 2. So that was one thing. And then a connectivity, in terms of amygdala frontal connectivity, we kind of, remember I told you before at baseline, this was, the severe group was lower than the none. You can kind of see that again here. Yellow is not as severe and none is black. And then you can kind of see it's a little bit different trajectories for mild and moderate, but if you just focus in on like the none and the severe, you can kind of see they're sort of similar pattern. They're both decreasing, and overall this connectivity does decrease with age in our sample, and it's just kind of stays lower for the severe group overall. And this connectivity was inversely correlated with suicidal thoughts as well. So at each time point, the lower connectivity, people with lower connectivity also had higher suicidal thinking. So let's see, what about the pandemic? We did, our study was halted during the pandemic. We reached out to all the participants, asked them if they wanted to participate in a survey. And so we kind of during June, August, and October of 2020, we collected data from them. We asked them what how they were doing, and kind of asked them to fill out a bunch of different reports about their self-injury, stressors and different things. So just a little bit from there, we've kind of looked at like who continued on with NSSI versus stopped there were some people who stopped or desisted. So we had this persist versus desist comparison. And so for those who persisted versus desisted, they were higher, as you might imagine, on perceived stress and loneliness. And the desist group had more family support. So again, like the kind of underscoring this importance of not just working with the child, but working with the family, and the importance of those relationships. And then, I would say our most important questions were here, but we also compared, against those who had never NSSI, and with the persist, you probably aren't too surprised they had more emotion regulation difficulties. And in terms of never versus persist, they had more friend support. We also did look at some of our neurobiology findings. And so greater pre-pandemic amygdala activity predicted persistent NSSI and perceived stress during the pandemic. So again, with the amygdala connectivity activation to threat being a signal for worsened outcomes. So that's all I'm going to share about the longitudinal data. Again, I hope that soon it will be ready to be uploaded, and people can do some of their own analyses. I think the advantage of doing of this data set, even though it's so much smaller than the ABCD study by many, many factors, it's looking at we have much more deep and rich sort of assessments in terms of the psychopathology. So there might be ways to look at these different kinds of data sets in parallel and ask different kinds of questions that are complementary. So just a plug for that. And since I wanted to have this talk be clinically oriented, I'm going to share some thoughts about intervention. I will say we don't have a ton, we're kind of, as a field, we have a lot of room to grow. So these are more sort of just my thoughts at this point as a person who's been researching this for, 15 years, and also a person who's been treating people for this long. And so I think taking a holistic approach that considers the child from all angles is something I want to encourage. And I'll talk about these kind of points in the coming slides, but just to sort of set the stage. So number one, ensuring safety and addressing severe stressors is critical and hard to do. Working with the adolescent to directly address these negative emotion states, because remember, we looked at why they're self-injuring, what is happening in the moment, and they're most commonly like doing this because they feel terrible. How can we help them with that, right? So can we help them with skills? Can we help them with ways to self-soothe? Can we give them medication that would, decrease that feeling in some way? And then working with parents to help them in how to support their teen. I think this is an area that needs to be studied more. And then I'll just be kind of talking about some just basic and enrichment strategies to promote healthy development, just helping kids meet their milestones and try to become their best selves. So thinking a little bit more broadly at that point. So again, like addressing key risk factors. This is such a challenge, right? As clinicians, we don't always know. Sometimes we find out like 10 years later, like that we were treating the person and there was some kind of like abuse that was happening, and we could have, so I guess I'll just say it is hard, and if we could wave our magic wands, we would take away traumatic experiences that are happening to our kids, and we would have a massive impact on their outcomes. But it's hard to do, but we try. And then, so addressing safety issues in the environment, try to avoid further adverse experience, either abuse or bullying or discrimination or what have you. So what we can do to identify and advocate for our kids might be more impactful than medications or anything. Again, a lot of these kids have depression. So what are our strategies for treating depression in young people? This is kind of a summary. Psychoeducation and supportive therapy can be just enough for somebody with mild depression. If it gets into the mild to moderate range, we start recommending evidence-based psychotherapies like cognitive behavioral or interpersonal psychotherapies. And then in the moderate to severe range, we begin recommending like medications like SSRIs or combined medication and therapy. So these are excellent, and evidence-based approaches to treating depression, and there's a lot of room to grow, as everybody in the audience knows. We have DBT, so we don't have like a pill or anything for non-suicidal self-injury, unfortunately, but we have DBT. So that we have a lot of data that's non-suicidal self-injury and suicide attempts can respond well to DBT in adults, and more recently we have some very good seminal work supporting this approach in young people as well. So this is a great both kind of top-down and bottom-up sort of approach to addressing suicide risk and non-suicidal self-injury. Working with parents, I think this, as I mentioned before, I think this is an area that needs to have more attention, emphasizing the importance of the parent-teen relationship. So even though we have this shift of teens, having more, importance with their of the relationships with their peers, that doesn't mean the parent relationship is no longer important. It's still super, super important. And so leveraging that relationship as a support and helping parents, sometimes it's scary when they found out about their kid having self-harm and they don't understand it. And so they need a lot of education and support and help and not being judgmental and help and learning how to validate and coaching. So just a plug for that kind of approach. So I guess I would say broadly, so I think we have a lot of kids, or I do, at least in my clinic, who've maybe, they've tried CBT and DBT, they've tried SSRIs, they've tried different things, they've been in the hospital, and they haven't had great responses, and they've started to kind of lose hope a little bit in about treatments, and maybe like they've dropped out of things, and there's been an increasing focus in terms of their identity on the symptoms and their so how can we kind of get them re-engaged in things that are important to them? How can we kind of like inspire them, right? And build and getting them to connect. So these are sort of the and connection and meaning. So these are again, just getting at some of these key things that we saw in the motivations for suicide, that they don't have enough meaning, they don't have enough enjoyment, and there's not reasons to keep them on this earth. So how can we kind of go in an indirect way? General comments about just promoting healthy development. Again, just kind of taking a holistic view. I mean, how can we kind of make sure a young person becomes the person who they are supposed to be. Again, safety from harm, love and attachment, exposure to nature and green time, having learning opportunities, having the right nutrition and sleep, and learning emotion regulation. These are all things that I think we should be keeping in mind as clinicians and researchers about ways to help these kids. Something that I've been thinking about lately is using creative arts as a way to help kids with depression and self-injury and suicide risk. And I'm not going to get into it in too much detail because the work is still very new, but I've been collaborating with a poet named Yuko Taniguchi and some others to implement some creative arts-based interventions. And the reason that we think it's helpful is to kind of try to get at some of these like issues that we've been talking about in terms of like what's driving these suicidal thoughts and non-suicidal self-injuries. So lack of enjoyment, like by engaging in the arts, there can be ways of creating some opportunities for moments of joy and experiencing like the flow of that can happen in engaging in the arts. It's kind of a way to connect with other people. It can be to address the isolation and loneliness, and finding a new way of seeing oneself. So kind of like taking on the artist mindset and like seeing themselves as an artist. Ways of kind of getting at this rigidity and inflexibility and hopelessness. So these are kind of some of the, and I don't think the arts is the only way, but starting to sort of open our minds a bit and think of, we still want to look at medications and structured psychotherapies. And there's also sort of enrichment opportunities that we can think about for our kids and ways to sort of promote their healthy development in kind of, again, from all angles. So I think this is where I'll stop. I'll end with my acknowledgements, and I think I can take questions.
Thank you so much, Katie. This was fantastic. Very clinically relevant, so very much appreciated. So just a reminder, you can put questions in the chat. I'm going to start with a few questions that are already in the chat. Just a second, my chat just disappeared. There we go. So Marianne Davis was asking, have you looked at the reasons for NSSI by NSSI group, non-mild, moderate, severe?
That's great. I haven't yet. I'm going to write down some of these things, these suggestions. I think that is an awesome idea. I think we're still in the early stages of looking at that. Thank you.
And can I just pop in with a quick follow-up on that? As I was writing out non-mild, moderate, severe, realized after I sent it that non might not make sense. But if you have people who start at baseline at non and became NSSI, that might be a really interesting question also.
Yeah, and spoiler alert, we did. So we do.
I'm not surprised. That.
Because the thing is, it's so common, you know.
Yeah. Oh, I know. So, a generational change also that there's been. Yeah.
So thank you for that question.
So Ed, I don't know if you want to just unmute and ask your own question.
Yeah, I'm sorry, it's complicated. I'm just not familiar enough with the fMRI methodology in presenting fMRI changes in brain function and activation over time within a sample, because I did notice you had significant differences between how many patients completed 1, 2, and 3. Do you, in those situations, only present data at each time point on people you have complete data on, or are these essentially subsets of the primary sample that you're presenting on, and can that contribute to interpreting the patterns?
Yeah, that's a great point. Yeah. So right today, what I presented is, I would say, and what I'm going to present as a poster, I would say these are preliminary results, and they are just complete data. So there are ways, we have an interest in doing some imputation methods and have not done that yet. So I agree with you. There's concern, like are there sort of non-random factors contributing to who comes back and who doesn't? And I think there probably are, in the sense that, and I have to analyze this more, but I think that the more severe NSSI, we're more likely to drop out because they just have so much chaos, or they're, in residential or something like that. So we do need to address that issue and think about how it impacts our interpretation. And then the other issue that I maybe didn't mention is, but we're really important for longitudinal data is, especially for a task, there might be, accommodation effects if you've done a task before. I mean, maybe not if you've done, it's been a whole year since you last took it, or in some cases it was more, right? Because they might have missed year 2 or something because of the pandemic or something like that. But we need to think about that, like accommodation effects, especially for the tasks. For the resting state fMRI, it's not so much of an issue, more for those task conditions.
Brian Scan was asking if you're aware of any regional differences in NSSI, particularly with gender nonconforming youth, given changes in legislation in some states.
Regions of the brain associated with gender nonconforming? Was that the question?
Sorry, regions of the country. Yeah.
Oh, yes. I wish I had one of my students here. We have been looking at that, and there's some data set I know that you can look at, like that you can get like a value for the extent to which a state is intolerant or something, or tolerance versus intolerance, like in terms of their policies. And we have been looking at that in the ABCD data. We haven't looked at it yet with our data, which is mainly kids from Minnesota, but I think you can get county level data. So we haven't quite gotten there, but that is a super important issue. I think that young people who are living in certain parts of the country have more, minority stress type experiences versus other kids that live in, I think in our sample, the main issue is going to be Minneapolis, St. Paul versus rural Minnesota, where Minneapolis, St. Paul experiences are much more accepting and not so much in other certain regions of Minnesota.
I just don't think it needs to be that you have to live in an unaccepting area. I'm a mother of a transgender female, and every time a law is made in another state, the depression sits in, and she does cut. And I mean, we're getting her help, but we live in Massachusetts, in some of the most accepting areas of the country. And it's the fear is that rights are being taken away and we're going backwards in time. Yeah. So I don't think we should, it's just because they live in a certain area.
I think that's a great point, because the thing is, they're feeling the feeling of going backwards in time. And I think a similar process happened with the Roe v. Wade. Recently a lot of young people experienced a lot of us experienced that as a setback in terms of kind of the regime, like a feeling of living in a regime, an intolerant regime or something like that. And young people are not going to live in, they're not necessarily going to be in their like Massachusetts for life. Like maybe I want to go to college in another state. And I've certainly had, young people in my social circle say, oh, well, now I was considering, this state, but now I'm not going to consider that for college because of their, laws or something like that. So I think these are really important signs of our time.
We have another question from Carolyn Fredoff. From the qualitative data you presented, it seems like the adolescents in your study were very forthcoming about their NSSI. Is this typical for adolescents or individuals with NSSI? It seems different from the hesitant people with suicidal ideation sometimes. From the hesitance people with suicidal ideation sometimes have about disclosing SI due to concerns about losing autonomy.
Yes, this is a great point. I guess I will say my experiences in general, adolescents are pretty forthcoming, but speaking of, biases, I mean, these are study volunteers. They know in advance it's a study about, non-suicidal self-injury. So I think that I can't say that it's representative in that sense of all people with non-suicidal self-injury. And I know in my clinic, I have that same thing, young people who are really hesitant to share because they don't want to have to be hospitalized, or they don't want to have certain, privileges taken away or something like that. So I think it's a very fair point, and it really speaks to our limitations in our field. So we do kind of rely on our patients to tell us how they're feeling and what they're thinking about. We can't know if they don't tell us. So,
yeah. We have another question from Michael Aronson. Are safe relationships with family the biggest story here? What might be called relational health in terms of protective factor?
Is the question, what is relational health?
Is relational health a protective factor? Is a strong relationship with family a protective factor?
This is Mike. I worded my question poorly, but I think looking at the data, I think what I'm trying to figure out is kind of what's the biggest driver here, and is if we could just sort of wave a magic wand and just make each kid, despite the pandemic and despite laws that seem to make us go backwards, and is the relationship with the family, or what I call relational health, is that the biggest, is that the most important takeaway in some ways? Some of the data you were showing kind of really brought out how important the family relationship is, but at the same time, there are other factors. So I think I'm just trying to get at that relational health piece, and whether, how big of a story is it, or is it much more complicated than that?
Yeah, thank you. I don't know if I can say confidently that it is the biggest thing, but I do know that it is a important factor. And I think that, I wanted to underscore that it is not something to be brushed under the rug because they're teenagers and it's like, well, their relationship with peers is so important now. But I do think their relationship with peers, so I want to underscore that the relationship with the family is super important. And it's one of the main things that drive, suicide attempts and things. But the relationship with peers is super important too. And a feeling of connectedness and support is with peers and family are both important. And where they fall in the ranking, I'm not exactly sure, but I think we can certainly say that those are kind of really help with feeling like life has meaning, and it kind of perhaps one of the most important things. So sorry that I didn't have a super clear answer, but they're up there. Great question. Do we have any, or do we have time for more, Yael, or?
We have 1 minute if somebody has a question to add. So I see that Alex Sabo. Alex, do you want to unmute and ask your question rather than have me read it?
Yeah, I've been working the last year with Bessel van der Kolk and Ruth Lanius, and Ruth is doing really great work on fMRI research and studying people with developmental trauma. And they have a pretty amazing paper out on what happens in the default mode network and under pain conditions and not in controls and people with developmental trauma. And I was just thinking about what you're doing, Katie, which is so interesting. And there might be somebody in her group who'd want to work with you on that Bridges data set, because it's very much, they're exploring similar themes. And so I just wanted to throw that out there and just raise that.
Thank you so much. That I will definitely reach out.
Yeah, if you want, Ruth is going to give a grand rounds on her synthesis at our hospital in December, and I could send you a link if you'd want to come and see that, because it's very much related to what you're studying.
That would be perfect. Thank you.
Sure.
Well, thank you so much, Katie, for an excellent talk.
You're welcome. Thank you for having me.
Thank you.